there's still not fully kind of clarification why people with fibromyalgia are reporting swallowing difficulties in such high levels.
First of all, have you ever heard of fibromyalgia? To be honest, we had not until not long ago. Therefore, it was even more surprising to us that people with fibromyalgia often have swallowing difficulties. Besides the lack of awareness, researchers have only recently started to investigate dysphagia in people with fibromyalgia. In this episode, we speak with Dr. Órla Gilheaney, who is a speech and language therapist and assistant professor at Trinity College Dublin in Ireland. She's a clinician, researcher, marathon runner, and also a person living with fibromyalgia herself.
Hi, Órla. It's such a pleasure to have you on today's episode.
Hi, Julia. Thanks so much for having me today. I'm really honored to be asked.
To be honest, before the conference that you had organized together with Fibro Ireland in May this year, we hadn't heard of fibromyalgia before. Probably there are some, if not many, listeners out there who aren't familiar with this disease either. Could you explain what fibromyalgia is and what common symptoms are?
Absolutely. And I think it's a common thing for you not to have heard of it, which is unusual because it's something that affects a large percentage of the general population. But it's a chronic pain syndrome that's characterized by widespread pain and then some other associated symptoms like mood alterations, sleep disruption, and cognitive difficulties, all that come from the living with increased pain. Typically, patients show a heightened or augmented pain and sensory processing response when they're tested. And that's usually because there's increased connections in the part of the brain that are pro pain and then decreased connections in the part of the brain that are anti pain. And it's usually driven by things like imbalances in neurotransmitters. It's interesting that you said that you hadn't heard of it before, and that's something I hear a lot when you consider that up to 2 to 8% of the general population actually are living with fibromyalgia. So that's just below 1 in 10 when you think about it, Typically people with fibromyalgia have lifelong histories of chronic pain across their bodies with different bits of pain in different bits of their bodies at different times. Typically have quite a strong family history of it. And twin studies have shown that it's 50% genetic and the risk of developing it and 50% environmental. Unfortunately, females are usually 6 to 1 times more likely to develop fibromyalgia, and it can develop at any stage with prevalence across all countries, all cultures, and all ethnicities.
So I've just mentioned the Fibro Ireland that you have worked together with. Can you explain what it is and what it aims for?
Absolutely, yeah. So Fibro Ireland is a wonderful organisation based in Ireland, funnily enough, and it's run by people with fibromyalgia and living with fibromyalgia. And it aims to educate and support people living with that condition to kind of live well. They've got a wonderful leader called Rachel Lynch, who was heavily involved in organising our Fibro Forum conference. And she really drives educational activities, all aimed towards helping people themselves to educate themselves in fibromyalgia, in treatment options, and to live well with it. I first came to know them through personal capacity, and then as I came into academia and I was interested in looking at dysphagia and invisible illnesses, I got the chance to work with them on a more professional basis, and it's been a pleasure to do so.
So, you yourself, you're not only a clinician and a researcher, but you're also a person living with fibromyalgia. Would you mind sharing with us how this manifests in your case and how, if at all, it influences your daily living?
Absolutely, yeah. It's something I'm not shy to speak about because I think it's really important to show that you can live well with it.
And I mean, you're an athlete, you're a runner. You run like how far? 30 kilometers. So you would never think, for anyone who doesn't know you, you would never think that you're living with such a disease. I didn't know.
Yeah, and I think maybe that in itself is kind of a double-edged sword as well, I suppose. Um, Well, when I was kind of 14, 15 or so, I became quite unwell, kind of autoimmune symptoms, I suppose, first of all, fainting, kind of weakness, lethargy, that sort of stuff. And then over a week or two progressed into quite severe pain. And I was very lucky in that I had parents that very much we're privileged to be able to push for a diagnosis and bring me to countless doctors, countless different sort of healthcare professionals, and quite what seemed like quite a long time for us, but what is quite short now that I understand the diagnostic journeys people go through. But within about a year or so of still living with that chronic fatigue and pain and difficulties, I was diagnosed with fibromyalgia. And at the time, not to age myself, but at the time, it was about 15 years ago or so, and it was very unusual for a young person like that at that stage to be diagnosed with fibromyalgia. Now in 2022, we know that most people, through research, we know that most people with fibromyalgia do develop it in their early adolescent stage. But when I was being diagnosed, it was kind of incorrectly thought of as a disease of older aged females, I suppose, because that was typically when people were presenting to the doctor, or that fibromyalgia was considered as a diagnosis for them, if you understand. Like previously, it wouldn't have even been thought of in younger people, and there was no research around it. So I suppose since that age, I've been living with quite severe 10 out of 10 body pain across my body for the last 15 years, and really severe chronic fatigue with that, difficulties such that it would flare up and down, different, I suppose, neurological symptoms. Like I'd have quite a bit of paresthesia or burning, tingling, itching in different kind of neurological regions of my body, difficulty sleeping, and then the what is commonly spoken about, the fibro-fog, when you're in really bad pain. It can be difficult sometimes to think straight, that sort of stuff. You've got to put different mechanisms in place to help you through those times. But your functionality, I suppose, to put it mechanically, can go up and down based on how your fibromyalgia is. And I suppose what a lot of people would see is the running the ultra marathons or that sort of thing, or the lecturing and then also working in a hospital, or but what a lot of people wouldn't see is the some days having difficulties tying your shoelaces, or getting out of bed and that sort of stuff. So it is very much, and a lot of chronic illnesses day to day different.
Yeah, absolutely. So how do you manage living with the disease, the symptoms, and then, like you said, giving lectures at college, working in the clinic, doing your research, doing sports?
Well, some days I manage it better than others. I'm sure as we're all similar in that sense. And the way that I manage it is in no way to say that that's the way it would work for you or Hula or anybody else. I try to manage it through a lot of pacing. I'll be very careful with things that I'll take on, because I don't know if you've heard of the spoons theory. It's just a way that oftentimes doctors will speak to people with chronic illness, that you've only so many spoons per day.
Mhm.
And let's say walking into work might take two of your five spoons, or washing your hair might take one of your five spoons. So I try to pace myself in terms of what I'm taking on, be really careful with that. I try not to do too many things that will exhaust me or cause me pain. For me personally, and this is not the case for everyone with fibromyalgia, I find activity helps me to manage my pain, because a big issue for me is that I've got really significant amplification of pain. Like that's it. That's one of my really big issues, that oftentimes I'll have really severe pain in the absence of a peripheral input. So it'll feel like I've broken my arm, but I won't have broken my arm, if you get me. But the
Mhm.
pain is very much real,
Mhm.
because the neurotransmitters and the signals that are being sent out from my brain are as real as if I had done that, if that makes sense. So for me, I find that exercising gives me a good barometer of good versus bad pain, if that
Mhm.
makes sense.
Mhm.
And it's kind of a good way of training my brain to recognize the dangerous pain versus the non-dangerous pain, and keeping me fit and mobile. Because when you're chronically ill, you can then have the secondary difficulty of becoming immobile, developing
Mhm.
secondary illnesses, things like that. Now, I will say as a caveat, possibly of no relevance to that question, but for people with fibromyalgia who are very active, it can run the risk that they can get injured quite easily, because it can be difficult to recognize the symptoms of an injury coming on as compared to your day-to-day living. So things like you mightn't realize you're getting a stress fracture because your leg always hurts, or things like that. That's a by the by. I don't currently, while it is recommended for people with fibromyalgia to take medication ongoing to manage their pain, I don't currently at the moment take regular medication, but I do take as needed, if you get me. So at the moment, I'm not currently on a medication regime, but I have been in the past, and I have an excellent GP and physiotherapist, both of whom help me to live quite well with a lifelong condition and adapt through stages in my life.
Yeah, wow. That's a lot, and like you said in the beginning, those invisible diseases. It's really, I would have never guessed that you are living with such a chronic illness, and it's it's really interesting to see what a body can hide. And I mean, as clinicians, we're kind of used to this swallowing impairment that is invisible. And we always talk about or talk to patients like saying, yeah, well, we can't look into your throat. You cannot see it. Maybe you can feel it, but maybe your sensation is impaired, so you can't even feel it. And yes, I think it's so important to raise awareness and to talk about it and to make these invisible diseases more visible.
And to really situate the patient as the expert in it,
Yes. Yeah.
as exactly what you said there, Julia. Like I always say to people I work with, like I don't have X-ray eyes, I can't see what's going on in your throat. I'd love to, but I can't. But the really important thing is that you're believing the narrative that your patient is telling you. It's an awful lot harder to fake being well than it is to fake being sick.
Yes.
So it's always really important to kind of centralize your patient's narrative in your history and the way you work with them.
Yes, definitely.
You've already mentioned the medications, and that this is one thing that is recommended to some people living with fibromyalgia. What other treatment options are currently available, if there are any other?
So typically they recommend that a kind of a really integrated multidisciplinary approach is the best medicine. And that's usually a combination of pharmacological and non-pharmacological treatment. And really the key to making sure, regardless of what treatment that you choose, the key is making sure that you've got an enthusiastic and motivated and supported patient that can work with a compassionate and empathetic clinician as well. So typically fibromyalgia can be diagnosed and treated in the primary care setting, calling in those kind of specialist pain doctors where needed. But there is a range of different treatments that can be used. So for example, central nervous system acting drugs, non-pharmacological therapies. So you can have things like education, physical therapy or physiotherapy, exercise, as I mentioned, things like cognitive behavioral therapy. And that's really important because it can teach you the skills to live well with a chronic condition. It's really important for a patient to be skilled in the area of living well, regardless of what their condition is.
May I ask if you've done something like this, and if so, what strategies you apply, for example?
I went to cognitive behavioral therapy when I was a teenager when I first got diagnosed, and it was only for a few short sessions, but it was a course kind of, what's the word? Targeted, sorry. So it was a course that was targeted at people living specifically with chronic illness, so not necessarily fibromyalgia, but things like rheumatic disorders like arthritis and that sort of stuff. And it's a good way of helping you to recognize when you are approaching a flare up in your condition, being able to act on those different triggers that you've noticed, and then being able to either halt or go through a flare quite well, as opposed to letting it totally immobilize you. I found it quite helpful. And I know that Fibro Ireland, for example, runs Living Well with Fibromyalgia courses in conjunction with Arthritis Ireland that I'd really recommend to clinicians or patients that are living with it, because it just teaches you those skills, those generic but really important skills of living with a chronic illness. And those non-pharmacological therapies like your education, your physio, your exercise, your CBT, they all actually have really strong evidence in terms of helping somebody to live well with fibromyalgia, and taken together, the magnitude of their impact on helping someone live well actually far exceeds that of medications. So that's why you need the conjunctive work of the baseline of the pharmacological central nervous system working drugs in conjunction with the non-pharmacological therapies to help you to really get that strong foundation. But unfortunately, for a lot of people, whether it's financial, logistical, where they live, so geographical or other issues, access can be really limited to all of those treatments. And oftentimes as well, it can be dependent on the clinicians that you attend and their level of awareness of fibromyalgia, understanding of the treatments that are available, and then the person's unfortunately financial ability to access those therapies themselves.
What I thought when you were talking about the treatment and education, or what really impressed me, is that you said you train your own brain to distinguish between the good pain and the bad pain, and what is
Mm-hmm.
the, let's say, real pain because you're injured, and the other pain that is not caused due to injury. How does that work?
Well, I would always say that all of the pain is real. Do you know what I mean? Like the pain is real, but some of it is centralized. So that means that your neurological system, your central nervous system is the problem. Some of it can be neuropathic, so that's like nerve damage, and then some of it could be nociceptive, so that's inflammation or damage. So all pain would be real, but some of it just wouldn't have an identifiable peripheral cause, if you get me. So for me, like even before I became ill, I was really physically active. Like, I came from a very sporty household. So used to the physical feeling of having done a hard workout. You know, your legs are lactic the next day, you're really sore, you've got like that delayed onset muscle spasms, that sort of stuff. But when you become ill and you become immobile and you're used to just horrible centralized pain all the time, you can begin to think that that is similar pain to, let's say, for example, an acute injury pain. But through doing things like exercise, you can understand that, okay, this was related to a specific activity. I understand that this pain is perhaps muscular as opposed to centralized pain. You know, I can understand from where the pain is in my body. Because, for example, inflammatory pain is usually like localized, it's usually consistent with a certain activity you've done. You're doing squats, your bum hurts, you know, the next day, or, you know, you're doing calf raises, you can't, you know, walk the next day. Whereas centralized pain is usually quite widespread, and it's accompanied by things like fatigue, sleep difficulties, memory, mood difficulties. And there's usually no kind of history of something that would have caused that pain the day before. So it's a good way of kind of training your brain by journaling, writing down things that are causing additional levels of pain, tracking your pain levels, your mood, your sleep levels. And it certainly worked for me in that sense. It hasn't changed my pain levels, but it's helped me to recognize perhaps dangerous versus non-dangerous pain a bit more.
Okay, interesting. Okay, let's go back to the diagnosis or the process of diagnosing fibromyalgia. What is the typical route that patients go down?
Oh, that's a difficult one. Because unfortunately, there's no real typical route, because so if I can go back a little bit in history to kind of give you a bit of context on it. So up until around the 1970s or so, there was a large emphasis on the fact that this was a psychogenic illness. And that mirrors other clinical conditions, such as, you know, MS was called hysteria for a long time because we didn't have the diagnostic tools to actually diagnose these things appropriately. So up until the 1970s, typically patients would have just been examined like where the areas of tenderness. So they would have, you know, checked different areas like your bilateral elbows, your bilateral shoulders, a point in your lower back for different focal tender points. And if you had a certain number of sore points out of those 18 that they checked, you were typically diagnosed as having fibromyalgia if you had tenderness. that, or depending on the doctor that you went to, you might have been diagnosed with something called psychogenic rheumatism, which meant that you in your head had observed other people living with rheumatic diseases and you had then functionally developed a psychogenic disorder. Now, both of these things were not really helpful to the patient living with fibromyalgia, because to say to you that those tender points are tender on nearly everybody, they are. They were not really helpful in the diagnosis of it. And if I were to touch you, for example, in certain parts of your elbow, they'd also be quite sore. And also the taking the viewpoint of the psychogenic illness was actually really damaging to people living with the illness, because it meant that they were no longer taken seriously. They were kind of written off as people living with just simply a psychogenic illness, as opposed to what's actually a chronic widespread pain difficulty that happens because there's a problem in your final common pathway in your brain that causes centralized pain. And now, thankfully, it's seen as not just a discrete syndrome of pain and fatigue. Now we understand that, it's actually a centralized pain syndrome that's happened because of adaptations in your central nervous system that then cause it to amplify pain signals. And that can then generate perceived pain and very real but centralized pain in the absence of kind of an acute illness. Now, it overlaps quite an awful lot with other conditions, which makes diagnosis difficult. So, can overlap with things like chronic fatigue syndrome, migraine, temporomandibular disorders, which is what I did my PhD on, irritable bowel syndrome, and endometriosis. So there's quite a lot of similar syndromes that make it difficult to diagnose. But nowadays, thankfully, we've moved on from that quite limited view of diagnosis and just labeling a patient. And now clinicians do things such as they take an overall symptom severity illness. So they look at different nervous system symptoms that typically come with centralized pain. So you've got your fatigue, your sleep difficulties, and they usually mark that out of a 0 to 12 scale. And then in conjunction with those symptoms, they then look at a widespread pain index. So it's not just pain they're looking at now in the absence of an injury. They're now looking at a range of different symptoms. And you might find this interesting, but at the end, when you have your score from both of those two scales, you actually get ranked with a level of what's called fibromyalgianess, um, which seems like a made-up word, but it's actually a medical term, and it kind of rates how severe your fibromyalgia is, while also taking into account that it can vary day to day. So that score is never going to be Orla is a 12 or that sort of thing. It's it's going to vary. But diagnosis has certainly come on massively in leaps and bounds in the last few years, thanks in a large part to researchers such as Dan Claw and the researcher that I ran the Fibro Forum with, Andrea Chadwick, really pioneering pain and anesthesiologist doctors that have put massive amounts of work into really modernizing our view of these sort of conditions, not just fibromyalgia, but other invisible conditions. In research, you will see things such as MRIs being used in diagnosis, where you can see changes in brain functioning between people with fibromyalgia and not having fibromyalgia, but that's not unfortunately yet translated into clinical practice, but it's very much an established pattern in research papers.
And you just mentioned that the pain or the symptoms vary from day to day or within the day. Is it also progressing over time? So does it usually get worse the older you get?
Typically, so if we think of fibromyalgia just on its own, so let's say I'm a patient who has no other health condition, very unlikely because fibromyalgia typically co-occurs with other things, but let's imagine fibromyalgia itself will not become progressively worse. It just fluctuates over time based on other factors such as environmental, psychological, other physical issues, nutrition, sleep, hydration, that sort of stuff. But fibromyalgia can worsen as people get older due to the effects of other co-occurring conditions. So as overall health gets worse in general, it can have an impact that the fibromyalgia can worsen, but it independently typically doesn't. It can cycle through flares and good periods.
Okay, that makes sense. So now the big question that probably the listeners have been waiting for as well. How does fibromyalgia impact swallowing?
Oh, it's a hard question, isn't
Yeah.
it? And I think had you asked that maybe 3, 4, 5 years ago, there probably wouldn't be an answer for you because research has only recently started to look at this. So there's still not fully kind of clarification why people with fibromyalgia are reporting swallowing difficulties in such high levels. There's only been kind of tentative suggestions so far. So things such as, multiple medication use, things such as altered final common pathways I spoke about earlier, the central nervous system difficulties and things such as the impact of poor sleep and cognition. But the reason why I suppose I started to look at it was that I was already researching other invisible illnesses, such as, temporomandibular disorder, rheumatoid arthritis, and that paired with, so you start to see mentions of, very slight mentions of, swallowing problems and chronic pain conditions. And then that coupled with me speaking to people living with fibromyalgia, I started to hear more reports and more reports of, gosh, sure, I only eat soft food, or I couldn't have that, I choke, or that sort of stuff. And it just really piqued my interest in terms of what's going on, what's going on there? Why are people experiencing these issues? When I started to look at it, I started to look at it by doing a systematic review with my colleague, Andrea Chadwick. We found that there was not much objective data available at all to tell us what was happening and who was it happening to. And in fact, we only found actually 6 relevant studies globally that spoke about this topic. That then led to this long-winded way of telling you what that led to. But last year, I was lucky enough to get a research group of undergraduate students who had a real strong interest in looking at invisible illnesses. And we managed to conduct 5 studies with people with fibromyalgia to look at their swallowing. Now, one of them was an anonymous survey carried out last year by Catherine Costello, and we had nearly 2,000 people who were over 18 living with fibromyalgia globally. So it was great in the sense that we got such a large population. And people were reporting a range of swallowing difficulties, right? So this ranged across your kind of mechanical difficulties swallowing. So things such as 70% said swallowing tablets took extra effort. 69% said food stuck in their throat regularly. 58% were coughing while eating. 53% had painful and stressful swallowing. And 50% said swallowing liquids took extra effort. But then, interestingly, we also had a large cohort that reported altered sensation inside their mouth. So things such as 85% said they regularly had a dry mouth. 50% had altered or unpleasant taste. 40% had paresthesia or burning and prickling inside their mouth. And then going along with this, 30% had actually regular painful mouth infections. So that kind of said to us, gosh, there's a wide range of symptoms going on here, maybe not all within our classic definition of dysphagia, but all contributing to difficulties eating or drinking. And then when we paired that, we looked a little bit further into that one, and we found that 67% actually had reported esophageal difficulties as well, so going beyond the oropharyngeal stage, and 27% were losing weight unintentionally and uncontrollably. So potentially due to their swallowing difficulties, changes in their diet. When you think about that, considering the fact that a systematic review had only found 6 articles that were relevant, and just to throw this in anecdotally, not one of those articles had actually aimed specifically to look at swallowing of fibromyalgia. It was an incidental report. When you pair that with those results, it's actually quite shocking to see that globally dysphagia is actually quite a large issue in this population. So that really piqued our interest in that sense. And a couple of the students went on then to go beyond that quantitative issues to look at the qualitative piece and kind of look at, well, what are the patients themselves saying? Patients spoke an awful lot about physical and sensory issues, like difficulties eating their regular food, only having really soft but nutritionally poor food. They spoke about things like regular choking, regular chest infections, relying on blenders to actually be able to get any nutrition into them. And then alongside that as well, you had the psychological and the psychosocial issues of losing those social connections, not being able to go to work because of these swallowing difficulties, and all added up to show us that actually there's an awful lot of dysphagia within this cohort. Even if we're not sure of what's causing it at present, it's an area that needs more research into it.
Yes, definitely. So earlier you said that due to the pain, affected people can get more immobile, which makes sense. And we know that this can impact the swallowing function as well. So do you think, or do you know if the participants who answered the questions, if they were rather immobile or still active, or do you think that this might have an impact on swallowing?
Well, I mean, the study, it's a really good question. And the study definitely wasn't looking into causation. It was very much just a first step. But I do think it's probably logical that with a higher level of immobility comes a higher level of general overall disability, So I can certainly see that there could be a case for that hypothesis. And especially when you consider as well with higher levels of immobility also probably comes a higher level of polypharmacy as well. So, I can definitely see the logic there. And it's something we're really interested in doing in terms of really nailing down why is this happening. And just to flag here that, fibromyalgia is a syndrome and it's overlapping with many other conditions as well. So it's probably going to be a difficult one to nail down precisely in terms of causation with a one line statement or, a one sentence of causation because it's that complex and there's different challenges for people because the multiple symptoms of this disorder and not just the symptoms, but then the resultant obstacles that people face because of them.
Yeah, or the multimorbidities.
Exactly.
So many variables.
But I think we shouldn't let that complexity put us off looking at it further,
Not at all.
I think that should almost spur us on, and we shouldn't just be researching fibromyalgia. We should be looking at those conditions that also overlap.
I'm still thinking about all the different symptoms that you were mentioning. So many and so
I
many different
know,
ones.
I
So
know.
I guess treatment is also very challenging and complex.
Mm.
I suppose. Can you give some recommendations on what might help in treating the dysphagia?
Yeah, so I suppose just to say, first of all, that our research hasn't progressed in terms of giving recommendations for treatment just yet. We're still very much at the epidemiological stage of looking at its prevalence and its nature. But certainly there's some generic recommendations that we would give to people at this stage that we would give to many people living with similar symptoms. First one is always to report any difficulties you're having to the relevant healthcare professional and look for a referral to speech therapy if that's available in your area because it's important to get linked in with those clinicians that know their dysphagia inside out. It's very important. Then going on from that, at this early stage of research, we would really recommend that people are observing kind of safe swallow strategies, as we would recommend to people living with many different disabilities or different illnesses. So that's things around your posture while you're eating and your behavior while you're eating and your alertness. But also look at things like your eating and drinking techniques. So your small sips and your small bites of food and liquid, using liquid washdowns where appropriate, clearing your mouth before you've swallowed, using a straw if appropriate in certain cases, and to try and avoid, talking while you're eating because your nervous system is already dealing with enough, never mind coordinating talking and eating and drinking. And then we do speak a little bit, and we did speak a bit at the Fibro-Forum conference around diet modification. And the reason why we went there is because so many people are reporting self-modifications of their diets already in the absence of any medical help. And the thing we would always say is to, if possible, consult with a nutritionist or a dietitian before you alter your diet just from a nutritional standpoint, and consult with an SLT if possible to make sure that it's the appropriate texture for your swallowing. But we would recommend that for people living with fluctuating symptoms, it's really important to keep a log of what is and what isn't working for you from a diet point of view, from Are you having to modify it more this week? What foods are working for you? What foods are too difficult for you? And then looking at things like a little bit of diet modification around using things like gravies where appropriate, or cutting up your food in smaller amounts. Now, this does seem like quite basic advice that I'm giving, but unfortunately at the moment, the very first research into this has been done in the last year. So we are reticent to give too many complex recommendations at the moment. But that is where the research is going next. And through the organisation of the Fibro Forum, we have actually arranged a patient and public involvement group that are going to be working with the department going forward to help design research into areas such as treatment that was reported as a patient priority. So looking at things such as what is being done currently, and then once we work towards understanding the profile of symptoms that people are living with, what can we do to help? So while we're at a very basic stage at the moment, that doesn't mean that will always be the case.
Yeah, that sounds really like relevant research that we really need, and especially for clinicians to know what we can offer, how we can best offer diagnostic and treatment, and of course for the patients to get the best treatment available.
I think you just hit the nail on the head there, Julia. Like the most important thing at the moment, while we're in that transitional stage of research, is encouraging the PPI, so encouraging patient involvement in research, encouraging patient and clinician communication, and kind of mutual respect and empathy and understanding, honoring the patient's story so that we can continue to get this rich narrative around what it's like to live with these conditions so that we can then understand how to treat them, and then really promoting that patient-led research into the future.
Absolutely. Thank you so much, Órla. Thank you so much for taking the time and for talking so openly about your experiences as a researcher, clinician, and a patient yourself.
Is there anything that we forgot to talk about? Is there a take-home message that you want to give to us and the listeners?
Well, first of all, I'd like to thank you both for giving me the chance to speak to you and your audience about this. As we said at the start, seemingly rare, but actually not condition. It's something that affects an awful lot of people and can cause an awful lot of social isolation. People can feel really alone in living with it. But I think through activities like this and through the recent PPI we've done in the department, we can actually start to shine a light on it. And while we're still at that very basic stage, I think it's really important to do activities such as this to spread that awareness. The take-home message that I would really like to share is that it's so important to really center that patient's narrative. So when your patient comes to you, sometimes we have to suspend what we think we know about conditions, because I know I certainly didn't learn about these invisible conditions in college. I know in certain colleges it's changing now, but it's still rare to be taught directly about them. So we sometimes need to suspend what we maybe feel we have in our expertise arsenal, and understand what the patient is telling us and really believe them and honor them and go with them on their journey. So I think that's the main thing for a clinician to do at the moment. So to stay curious, stay inquisitive, and stay respectful of what the patient is telling you. And from a patient's point of view, I think it's really important to, before we know treatments for the dysphagia, to ensure that you're living as well as possible with the general fibromyalgia. So doing all those non-dysphagia specific treatments we spoke about earlier on, engaging with empathetic healthcare professionals, getting that support network, and then making sure that where possible, when you're well, you can link in with things such as patient-led research when you're able to do so, so that we can all ensure that everybody's priorities are met in the research going forward into the future. I just want to thank you both again for having me. It's been such a pleasure.
We hope you, our listeners, enjoyed this episode as well. If you would like to get in touch with us and stay informed about upcoming episodes, you can follow us on Instagram at Dysphagia Matters, on Twitter at DysphagiaPcast, or visit our website, dysphagiamatters.org. Thanks so much for listening. Thank you, Órla, for coming on the show, and take care, everyone.